Correct.
Yes, ma'am, I'm ready, ma'am.
So we will go live. Chitrakala, are we ready to start now?
Yes, ma'am. Yes, ma'am.
So, the Obstetric and Gynecological Society of Southern India welcomes everyone for the Auxi Clinical Research Hour thesis discussion. We welcome our faculty, Dr. Uma Kalyana Sundaram Madam, HOD, Sundaram Medical Foundation, Dr. Sunita Samal Madam, who's the consultant, senior consultant at, so let me read.
Next slide.
TV, Senior Consultant, Department of Obstetrics and Gynecology. The previous one, Chitrakala.
Uma Madam CV.
MBBS and post graduation from SAID GS Medical College and KEM Hospital, Mumbai. Member of FOGSI, OGSI, IMS, CMS, IAG, RCOG. Presented papers and poster in national international conferences. Faculty in PG revision course and conference. DNB practical examiner. Special interest in high risk obstetrics, subfertility, endoscopy and academics. Dr. Sunita Samal Madam. Next slide. She is a consultant obstetrician gynecologist and laparoscopic robotic surgeon at Apollo Women's Hospital, Chennai. UG PG teacher, 16 years, DNB faculty, special interest in minimal invasive gynecological surgery, high risk obstetrics, basic fertility and medical education. 54 publication variation national and international journals. Awarded best poster award at AACOG 2015-2017, first prize in FOGSI Zonal Quiz 2002. Anjalakshi Chandrasekhar Award for Best Research Paper 2020 Oxicon, International Scientist Award on Science and Medicine 2021, organized CME workshops, presented paper faculty in various national international conference, member FOGSI, OGSI, IAG, ISUOG. Next. Dr. Bona ma'am, she is a professor and senior consultant at Srihar, Chennai, active member of ATN, RCOG and OGSI, organized annual postgraduate revision course and workshop in Srihar, Chennai with 24 years of clinical and teaching experience, part of ATN RCOG and MRCOG training course faculty and part 3 MRCOG examiner, undergraduate, postgraduate examiner, published papers in national, international index journals, had been invited speaker in conference areas of interest, endoscopy, high-risk obstetrics and vaginal surgery. And now we welcome our conveners, Dr. Umaram. We have the CVs, Dr. Umaram Madam, Senior Consultant, MRCOG Part 3 Examiner, Sitapati Hospital, NACTIV, OGSI Executive Committee Member, Dr. Deepa Thangamani Madam. She is an Executive Committee Member, OGSI, actively involved in academics in OGSI, as well as she is the Secretary, Chennai Menopause Society, actively involved in ATN, RCOG and CMS. And Dr. Deepa, Dr. Priya Kannappan, she is a Senior Consultant at Mehta Hospitals and as well National FOGSI Quiz Coordinator. Over to the conveners to take over the session and also introduce the postgraduates for thesis discussion for the next 1 hour. Over to you, madam.
Thank you, Meena. Thank you so much. And I will quickly move on to the thesis discussion. I invite my co-moderator Uma Madam as well as Priya. Uma Madam and Priya has already joined. And our moderator for the sessions, the examiner for the session is Uma K from the SMF as well as Sunita as well as and we have Bona from Ramachandra. All have joined. We'll go quickly to the first presenter. This is like they will be presenting their thesis outline and then they will discuss with the examiner whether they are going in the right route or wrong route. It's just for the for them to correct themselves. So first is Divyanka. Divyanka, are you ready? Can you discuss? There is no display. They will be discussing their topic, their primary, secondary outcomes, and their statistics as well as their.
Divyanka is not yet joined, I think, but Dr. Shakti, Jaipriya, and Soundri are there. Oh, Divyanka is there. Okay. So you're ready with your thesis topic, doctor?
Yes, ma'am.
Yeah, go ahead, ma'am.
So you just have to tell us what is the thesis about and then like, your at least, I mean, like whatever the right abstract, whenever you write, you have to just present the abstract to the examiners, and then they will be continuing with the discussions.
Okay, ma'am. Good evening, everyone. My thesis topic is immediate postpartum versus 6-week postpartum glucose tolerance testing for women with GDM. The
Can
aim
you
of my
open your camera if it is possible?
good evening, ma'am.
Okay, continue.
The aim of my study was to compare the OGTT levels between the postpartum day 2 to day 4 with the routine postpartum oral glucose tolerance testing, which we routinely do at 6 weeks for the diagnosis of type 2 diabetes. Mine was a prospective observational study done at Srihar, and the inclusion criteria were all the pregnant women diagnosed with GDM, and the exclusion criteria were the pre-gestational diabetes or the over diabetes women, and women who could not tolerate 75-gram OGTT test or were intolerant or allergic to the glucose.
So can I intervene here 1 minute? So in your institution, you follow DIPSI or you follow the IADPS, or which one you follow?
Ma'am, in our we follow the ADA as well as the IADPSC
So
criteria.
in your, so your for thesis purpose, which one you have taken?
Ma'am, ADA criteria only has been taken.
ADA criteria. Okay,
Yes.
that means you are going to do the OGTT, like that is 75 grams or 100 grams OGTT.
75-gram OGTT has been done, ma'am, in which for the diagnostic criteria, so there is something called impaired glucose tolerance and diabetes. But for my thesis, the impaired glucose tolerance has been replaced with the word abnormal sugars for the statistical analysis, and diabetes has been labeled as diabetes.
Okay, you go ahead in the methodology, we'll see. You just go ahead.
Yes, ma'am. So inclusion and exclusion criteria, as I've told, and then mine was a prospective observational study and done in Ramachandra, and the whole sample size was of 143, calculated with the confidence interval of 95%. Then for the methodology, after taking the informed consent of the participants, the OGTT was done using 75-gram glucose solution in fasting state at postpartum day 2, 3, or 4 of at the postpartum day 2, 3, or 4, and then again they were given reminders through the call or message, which is not a routine protocol but was done for the thesis, and they were given reminders to come back again at 6 weeks for a repeat OGTT, which is considered as the gold standard OGTT to diagnose the over diabetes state of.
Divyanka, a minute.
No.
So these are the patients whom you have diagnosed previously as gestational diabetes.
Yes,
So
ma'am.
postpartum once on the immediate postpartum
Yes,
and again at 6 weeks.
yes, ma'am.
What
So
is the cutoff
already,
you used?
ma'am, so the
Cutoff
cutoff
values?
which we used were of the ADA criteria, and in that the abnormal value was considered as a fasting of more than 100, like fasting value of more than 100, and 2-hour glucose value of more than 140 was considered abnormal. But if they had values of more than 200 at 2-hour and more than 126 as at fasting was considered as over diabetic. So using this criteria, all the patients were assessed. So all the patients in my study completed the initial day 2 to day 4 OGTT, but there was 30% loss to follow up when we went for the 6-week OGTT, despite continuous reminders.
I understand,
Okay.
Divyanka, sorry to interrupt, but are you able to get that whole 8 hours or 10 hours of fasting status in the postpartum period?
Yes,
Yeah,
ma'am.
that's
Because
what I mean
most
to
of
ask.
them will not be able to stay empty stomach for the whole night because they are breastfeeding and they are stressed out, isn't it?
Yes, ma'am, that was a criteria. 8 hours of fasting we were able to complete because the
No,
patient
1
had.
minute, because why I'm telling, see, why Bhuvna is also asking same question, because as per the protocol, any patient having a GDM, after 4 weeks, you are supposed to go for a GTT. Previously
Yes.
it was 6 weeks, now it is 4 weeks. Because when you are doing on the day 3 to 2, 3 or 4, suppose somebody has undergone section, LSCS. So day 2 also it is difficult for her to give the fasting sample, and with the glucose that lot of
Yes, ma'am.
factors
Because
can
of
be there. Yeah.
Because of that criteria only, day 2 to day 4 as a range was considered, ma'am. For LSCS patients, most of the patients were not able to give the sample at day 2 because usually the soft solid diet is only started at that time. So there was one
Yeah.
more criteria in the methodology which included that the patient should have taken proper soft solid or normal diet for 24 hours for the previous day and should have fasting for 8 hours. So, for the normal delivery patients, we were mostly able to do it at day 2 or day 3. But for most of the cesarean patients, like none of the cesarean patients was able to give on day 2. So that was done on day 3 or day 4 only.
But what is the rationale behind doing the day 2, 3, 4 GTT instead of doing a fasting PP in a GDN patient?
Ma'am,
Because as per protocol we do after 4 weeks. What you want to know extra from this
so
doing at the day 2, 3, 4 doing a GTT?
So, ma'am, there are various theories which are telling that most of the changes which lead to diabetes in pregnancy are the placental hormones which come down to the normal levels within 48 hours of the delivery. And because they come down to normal, so we should be able to diagnose most of the over diabetes patients. One factor is this. And the second factor is that there is, though in my study, the loss to follow up is 30% because of the repeated reminders, but in actual scenario, the loss to follow up is even around 50 to 60%. So none of the patients are coming back for 6-week follow-up, which is leading to much more complications later because of the late diagnosis of the over diabetes, leading to metabolic syndromes and everything. So in my thesis, what I found out is my specificity was 91% and my sensitivity was 91% and specificity was 47%. So this showed that although I am a little more over diagnosing the patients, so the one who are coming as abnormal OGTT may turn out to be normal at the end of 6 weeks, but I was able to diagnose all the over diabetic patients. So there were eight patients whom I had diagnosed as diabetic at 6 weeks, and all those 8 patients were actually diabetic at the end also in the gold standard test also. So my specificity and sensitivity for over diabetes is 100%. So I'm earlier able to diagnose the patients who will 100% be diabetic. So I can treat them earlier. I can give them lifestyle modification or the pharmacological, like after continuing follow-up with them, I can give them pharmacological treatment. But the patients who were diagnosed as abnormal, for those patients after after they being diagnosed that they may be at higher risk of getting diabetes, they were more compliant and they had they agreed to us to get to the lifestyle modification, and then they also are more compliant to come back at 6 weeks for the follow-up. So
Okay,
this can
one
be
more question I want to ask. One more question. Like those patients, like you have taken, whom 8 patients and some patients you got found to be over diabetic. Whether those patients during pregnancy they needed the oral hypoglycemics or they are on insulin, and whether they are on high dose insulin or what time, what gestational age they got GDM. Those things have you taken into account?
Ma'am, I have taken into account what drugs they were on. Most of the patients were on oral hypoglycemics or insulin. So out of the 8, around 4 of them were on insulin, and the 4 of them were on, out of 3 were on insulin plus OHA, and 1 was on OHA. And the gestational age at what they were diagnosed was not considered, ma'am.
Okay, Divyanka, a question about the one you did immediate postpartum on day 2, 3, 4. Okay,
Yes.
if they were found to be diabetic, what did you do?
Ma'am, they were
Did they repeat the test again at 6 weeks postpartum?
yes, ma'am. They
For the
repeated the test
purpose of the
again at
study.
6
Were
weeks.
they advised diabetic diet
Yes,
or
ma'am.
Or
They
were they
were
started on treatment?
they were advised diabetic diet, ma'am, and then they were but we didn't start pharmacological treatment for it. Only on diet they were there.
You have diagnosed them, but at 6 weeks again you repeated OGTT, not
OGTT.
your fasting PP sugars.
No, ma'am.
Any
Because they were
changes you found?
No,
Any
but
of them, did
one,
you find any changes? Any difference? Did
No,
they
ma'am.
also again positive for
All
diabetes?
showed positive. Yes, ma'am.
You
8
already
patients.
diagnosed them as diabetic in the first few days. So why did you want to repeat OGTT then? Why couldn't
yeah.
you do it directly?
Ma'am, because the
Repeat schedules?
exact
because they were comparing.
yeah, we were comparing and we were not very sure that if they are labeled as diabetic on the day 2 to day 4, should we label them as diabetic or not? Because it can be because of the pregnancy induced changes.
Then okay. Hmm. So we could
Then
go
why
ahead
didn't
directly
you,
at
yeah.
6 weeks rather than, right?
Then one suggestion, why don't you repeat at 4 weeks again? Because suppose those patients like you yourself only telling when you do on a day 2, 3, 4, there can be false positives.
Yes, ma'am.
So waiting for them till 6 weeks. So why can't you repeat the test like after 4 weeks?
Ma'am, we could have done it at 4 weeks, but just for the comparison and just for the
I think this is already
gold
study is already over. Yeah.
yeah, the studies, the gold standard which we considered was 6 weeks according to the WHO guidelines.
Yeah.
So to compare it at that time, we had to take it at 6 weeks.
That's what we usually do, right?
Yes, ma'am.
All GDM patients, we do the OGTT at 6 weeks. So you
Yes.
stuck to that. Okay.
Yes.
So can
And
I
yes.
ask a question? This is Uma. So I mean, very interesting because there is, I agree with you, there is a strong focus on trying to do a test immediate postpartum simply because not enough people are coming back to do the postpartum GTTs. I'm just curious. I mean, I know you've completed the study, but it would have been nice to have at that point possibly done a HbA1c or some such test, which will see, the biggest challenge, as everyone here has pointed out, is giving a glucose load and asking somebody who is immediate postpartum to stay nil by mouth or for 8 hours. In the real life setting, that is never going to happen. So if you had done an HbA1c and taken into other consideration, other factors like Sunita asked, duration, gestational age at which the GDM was established, whether she needed medication or not, what was her BMI, you may have been actually able to develop some kind of a correlation between all these factors and the GTT at 6 weeks. Because if you think about it, practically doing a GTT at 3 days is not something that's going to be translatable into clinical practice. It's fine for your study. So an A1C would have been helpful, but that's just a comment. But I'm curious to know, when you calculated a sample size, what did you expect will be the difference? Because without that, you couldn't have calculated a sample size, right? When we do a sample size calculation, we in our heads think this is going to be the ballpark difference that I'm going to get, and that is how you base the sample size calculation. So what was your
Ma'am,
that number?
in my parent study, my parent study, the parent article had a specificity of 55%, but now the same article has got a follow-up study, which they have followed up along with the HbA1c value and 1 hour follow-up of the patients who had a positive OGTT, and they have found a very positive correlation in that, stating that the patients who were initially diagnosed as abnormal OGTT are more prone to develop diabetes over 1 year of period. There were patients who had normalized the level at 6 weeks, but then again when they did it for them at 1 year, many patients turned out to be over diabetic. So this was my parent article in which they had done a follow-up study for the same. So in my thing, I have not done a follow-up study. And
No. My question is, how did you what was, what went into your sample size calculation? How did you get 145 as your sample size?
Ma'am, so after considering the confidence interval of 95% in the both thing and taking the precision of 10%, they calculated it like that abnormal glucose. So what I was supposed to get was the abnormal glucose level. How many patients will get should be 82, and some normal glucose level should be around 60. So along with that, if I would have had that sample size, that particular calculation of 82 abnormal and 61 normal, then I would have almost had more than 90% specificity and more than 90% sensitivity in both the groups. But my specificity came out to be more, and my sensitivity came out to be more, but specificity was lagged behind because the abnormal glucose level which was diagnosed was a little more than what was planned in the sample size.
Okay, so I think, yeah, well, I think you, I mean, need to understand a little bit more about how we calculate the sample size before you actually, if someone tweaks you and or particularly questions you on that, you need to know how to get that answer as well. Yeah. Okay.
Yeah.
Interesting.
So finally, yeah. So finally, total how many numbers you took for the calculation? Because you took a lot of patients lost for follow-up, like
Yeah, ma'am. So 143 was the calculated sample size, out of which almost 43 patients were lost. And so the final calculations were all made out of the 100 patients.
out of 100%, 8 are found to be diabetic.
Diabetic, yes, ma'am.
Okay, so in that, have you compared like those you told 4 were on insulin, and like have you compared with the risk factors, like as per obesity, advanced age, anything you have compared, or
Ma'am,
that comparison?
differently, they have been compared differently, like the age parameter and the BMI parameter. So, like overall, for the whole group I have studied, for the whole 100 population, so most of the patients were overweight in my study. Then considering the primi and the multi, most of them were primi gravidas, and then or the ones on MNT, OHA or insulin, most of them were OHAs.
You have taken both primary and multi. It is not only primary
Yeah.
para.
No, ma'am.
Okay, when you have taken a multi, whether previous pregnancy also they had a GDM, no, because you have just taken out the pre-gestational diabetes, over diabetic, you have excluded.
Yes, ma'am. So that was excluded, and then the average reproductive age group, like mostly 26 to 30 years old women were considered in the study. And then as I told previously, the postpartum day of doing OGTT was compared between the LSCS and the normal delivery patients. Most of the normal delivery patients, OGTT was done on day 2 and day 3, whereas in LSCS it was done on day 3 and day 4. And out of the total 100 people, what came was more number of abnormal patients. The patients who had abnormal sugars were a little more as compared to the normal.
How
So
many? How many? How many normal, how many abnormal, and how many diabetics out of the 100?
ma'am, out of the 100, as I told, 8 were diagnosed
8
as
were diabetic.
diabetic, and then 90 were diagnosed, out of the 143, it was 90 which was diagnosed as abnormal, but then there was loss to follow up. So 66 patients were diagnosed as abnormal, and
At the end of 6 weeks. Yeah, they were lost to follow up. So at the end of 6 weeks.
at the end of 6 weeks, there was 21 patients who were diagnosed as abnormal, and rest all were normal. But
Diabetic 8.
diabetic 8.
Okay.
Yes, ma'am.
8, 20, 22.
21.
Very
Yes,
good.
ma'am. 21 were abnormal and 8 were diabetic. But in the one out of the initial group, we had more number of abnormal people. It was around 66, ma'am, from the 100 group.
So what did you find out of the 66 abnormal? Most of them reverted to normal by the time 6 weeks, right?
Yes, ma'am. Yes, ma'am.
Any further
What is your
plans to
conclusion?
educate them as to their was any follow-up? You haven't done a follow-up, but did you educate them saying when they should have have their test done again? What should
Yes,
they do
ma'am.
next?
At the time of discharge, all those patients who had abnormal sugars, they were advised the diet plan. They were advised to continue their postpartum exercises, and then they were advised to come back after 6 weeks. And then again, we sent a reminder to them around 4 weeks to come back for the 6-week follow-up, or even they could the patients who had moved out of the city, they were asked to do it near their place and they
At 6 weeks, whomever you found as normal, abnormal turning to normal,
Normal.
did you keep a, what did
we
you
just
advise them?
we just told them that there may be chances that in future you may get diabetes because you had diabetes in your pregnancy. That means you are at high risk of developing over diabetes. So you need to take care of your diet and you
Hmm.
need to exercise regularly. But as of now, nothing has to be done. But you have to follow up your sugar levels yearly.
Annual, yeah. So
And
that's important, annual blood sugars in these
And
patients.
did you find anyone like at day 2 immediate postpartum that was normal, but after 6 weeks GTT was abnormal? Did you find anybody?
who was normal and turned out to be abnormal.
Yeah.
No, ma'am.
You didn't find
No, they
anyone.
were all
All of the normal ones had
continue
Like
to
post
be normal.
6 weeks GTT was normal. It
Yes,
was not
ma'am. So
abnormal.
that is
Okay.
why I was able to, once it comes normal, I was able to rule out that, okay, this person may not develop diabetes, but if it had abnormal, I was not able to rule out that it is definitely diabetic or it is not. So for that, 6 weeks follow-up was necessary.
No, it's difficult to convince them as well. If
Yeah.
it comes normal, they won't be willing to do again at 6 weeks, right?
Yeah. Correct.
So
Uh,
usually you will combine it with your postnatal checkup at 6 weeks. That's when we call them again, right? Approximately. So it's you can ask them at 6 weeks, do it and come back for your postnatal checkup.
Yes.
Yeah, I think here one more like the biggest challenge is doing a GTT in the immediate postpartum.
Ma'am,
They're doing
shall
it
we
Find
do
almost 100% compliance with our patients, all the GDM patients who come back, for the next postnatal checkup. By 6 weeks, they do it. Someone comes and shows us the report. We have been keeping tabs on that and almost 100%.
Madam, give her some tips and then we will move on to the next presenter, madam.
Yeah.
Final tips for her, Divyanka, any tips?
Divyanka should try and follow up these patients and see what happens. Like her parents study, that's very
Yeah.
important. Try to follow up the diabetics, the abnormal OGTT patients.
Yeah, that's very important. Yeah.
So good.
And also, suppose you have not compared already, the study is over, like maybe like what gestational age, like from the antepartum period also we can know who is going to be over, like who is over diabetic. Maybe in the first trimester you have diagnosed. So those things also like you can maybe before publication, this is for your thesis. So before publication, if you have the data, you can compare all those things.
Yes, ma'am.
Okay. Yeah. Thank you.
Ma'am. Thank you, Divyanka. So next presenter will be Dr. Sakti Jayapriya. Sakti, you can switch on your audio as well as video. You can start talk.
Good evening, ma'am.
Good evening.
Good evening, ma'am. I'm Dr. Shakti Jayapriya from Madras Medical College, and my topic is on comparison of metabolic and endocrine profile of lean and obese PCOS who are attending infertility OPD and their prevalence among the different PCOS phenotypes, ma'am. And mine is an observational study that is conducted in an Institute of Obstetrics and Gynecology, Egmore, and KGH, Triplicane. Mine period study is 12 months. And the study population is PCOS people who are attending infertility OPD. And the sample sizes, I am comparing the obese PCOS group 98 patients and lean PCOS groups 98 patients. And then the selection criteria is based on the consecutive sampling of lean and obese PCOS, ma'am. And my inclusion criteria in obese PCOS, the patients who are having oligo and anovulation and clinical or biochemical signs of hyperandrogenism with a polycystic ovarian ovaries in an ultrasound groups, and the age group we are analyzing is between 20 to 35 years of age group, and exclusion criteria is those who are having already thyroid dysfunction, who are on drugs, and who are known diabetics, hyperprolactinemia peoples, and women who are on having hormonal pills or primary ovarian failure or primary hypothalamic amenorrhea are excluded from our study. And methodology, this is an observational study was carried out for 1 year. Those who are attending an infertility OPD, those who are not willing to participate, and features who are excluded from the criteria are not included. And total 196 PCOS patients are included, comprising of 98 of obese PCOS and 98 of lean PCOS, and were studied in this group. And basic structural proforma is to collect the detailed history from the patient regarding their LMT and their past menstrual cycles, and regarding the amenorrhea, polymenorrhea, and all physical characteristics including height, weight, and BMI are calculated, and thorough systemic examination of hirsutism and other features of hyperandrogenism and insulin
So
resistance.
you have
were
taken
examined.
basically the Rotterdam's criteria to diagnose PCOS.
Yes, ma'am.
Rotterdam criteria. Okay.
And their metabolic profiles, basically we compared the fasting blood sugars, lipid profile. Fasting lipid profile includes HDL, LDL, VLDL, and total cholesterol levels, and serum LH, FSH, and serum total testosterone, serum AMH and TSH were taken, ma'am. These levels were compared and analyzed between these two PCOS
You have
groups.
taken only fasting blood sugar.
Yes, ma'am.
Not PPBS, no HbA1c, not
No,
GT.
ma'am, only fasting.
But you could have taken like either HbA1c or fasting PP or a GTT. Only fasting, how is going to help you?
Yes, ma'am.
You got my point,
Yes,
because either you can take a fasting, you have not taken fasting insulin, right?
Fasting insulin not taken, ma'am.
You have
Blood
not taken.
sugars
So
were-
fasting blood sugar you have taken, that's correct. So either you could have done fasting and PP or a GTT, or you can go for HbA1c also.
Okay,
So only
ma'am.
fasting you have taken, that's what I asked.
Okay.
But
Only
what is the your point not taking a PPBS or a GTT or HbA1c? At least you're doing fasting PPBS also can be done. That is not that difficult.
Yeah.
Why
Okay.
you have excluded the PPBS?
Yes.
Is there any idea behind this not taking a PPBS?
No, ma'am. Those who are having abnormalities in FPS, we are proceeding with the further evaluation, ma'am.
What would you evaluate further?
Uh,
What did you do? If abnormal FPS, what did you do?
PPBS and HbA1c, ma'am.
Then you did again for blood sugars and HbA1c.
Next visit, ma'am.
But I think it should have been included the fasting if I do it.
Exactly.
Either fasting and HbA1c or fasting PP. Anything
Okay,
can
ma'am.
be done. Maybe GTT patient because
GTT
lot
also,
of
yes.
yeah. So at
GTT
least
is
fasting.
accepted.
Yeah. So
Yes,
fasting PP or HbA1c, it is only fasting. I don't think it is good. Sometimes fasting may be normal, PPBS will be very high.
Okay, ma'am.
That possibility is also there.
Exactly.
Okay.
Yes,
Yeah.
ma'am.
Okay. Next. What other metabolic parameters you have taken? Lipid profile and blood sugar.
Serum FSH, LH, AMH, ma'am.
Metabolic
FSH,
profile. FSH, LH, and all are your
LH, they are
hormonal
not
profile.
metabolic. You told
You are
metabolic
studying
profile,
the
right?
metabolic
Lipid profile, ma'am. Lipid profile.
lipid profile.
Okay.
Okay.
So in a metabolic profile, lipid profile, and your
Endocrine.
sugar. Endocrine. Actually, endocrine also you have taken. So that is why you are telling FSH, LH, prolactin, and TSH. But FSH, LH you have taken on the which day of the menstrual period?
Ma'am, day 2 of cycle, ma'am.
Day 2 or 3 you have taken.
Yes, ma'am.
Okay. So you are able to get the patients on the particular day, all these patients on the day 2 and day 3 of the period?
Ma'am, usually in infertility OPD, we are instructed the patient to come on usually day 2, ma'am. So we are able to
so
get
that you can get.
yes, ma'am.
And
Okay,
how do you?
Jessica, one doubt. All these are diagnosed PCOS patients, right?
They any one of the
You have
features.
recruited already diagnosed patients.
Yes. She
So
told
why would
already
you
right.
want to do their FSH, LH and all again when we are only going to study the metabolic parameters here?
Ma'am,
She told, I
actually, we
think,
are
endocrine and both.
in infertility OPD, we are evaluating on day 2 for a hormonal profile, ma'am, for starting on
So you
infertility.
do all of it at the same time.
Ma'am?
So you do your metabolic and your hormones at the same time. Every
Metabolic and
patient who
hormonal.
enters- Okay, every patient who comes to the infertility OP, you're doing all this and then
Yes, ma'am.
segregating into PCOS, yeah?
Usually some people will come with a already outside ultrasound report with PCOS, ma'am. Some patient won't have all basic investigations, ma'am. But on usually day 2 before starting any
No,
infertility.
Jayapriya, what
Ah.
is the thing I understood is the people you are recruiting were already diagnosed as PCOS, obese and lean categories. You have
Yes.
separated them into, and then
Yes,
you're
I
going to
think so.
study the metabolic parameters. So that's why I did not understand why you are doing the hormones again,
Okay,
endocrine
ma'am.
study.
Yeah, I
Some are
think so. What
diagnosed,
you
ma'am, and some will be diagnosed in our OPD for first time, ma'am.
No, but when you told your study title, you told it is a PC, obese and lean PCOS. That
Yes,
means patients already diagnosed to have PCOS are come to your OPD and you are studying only the metabolic and the endocrine profile, right?
Yes, ma'am. Ma'am, actually, it's also included those who are patient already diagnosed and coming to our OPD for the first time. And those patient who are coming for infertility treatment, we have diagnosed PCOS also included, ma'am.
Okay, after diagnosing, you will do your metabolic parameters or you will do everything at the same time?
And
The
bas-
first persons who come for the first time. Okay, I
ma'am,
don't
basically, when you are first patients that are coming, no, ma'am, we are
you're
doing
doing them the investigations and
only
you're
basic.
doing lipid profile as well for all of them when they first come in.
No, ma'am.
After diagnosis only you will do, right?
Yes, ma'am.
Okay, fine, carry on.
Yeah.
And then we are categorizing them into the different phenotypic groups, ma'am. And basic phenotypic A, which is the most severe form that is characterized by hyperandrogenism and ovulatory dysfunction with bilateral polycystic ovaries, with the phenotype B and hyperandrogenism with ovulatory dysfunction, ma'am. Phenotype C and D are compared to be milder variety than phenotype A and B, and we are based on analysis we could be able to find out that
Just a second.
most of the
Both the groups, 1 second, Jaipriya, both the groups, lean and obese, both was split up into various phenotypes.
each groups are categorized into
different
phenotypes.
four phenotypes,
Yeah.
ma'am. And in my study, it is found that comparison of lean and obese PCOS groups, there is clinical findings is more among the obese PCOS than lean PCOS, ma'am. Like clinical findings like acne, upper lip hair growth, and hyperandrogenism features and acanthosis nigricans were more among the obese PCOS, whereas among lean PCOS, 61.2% were did not display any of the clinical findings, and their BMI also did not find with any clinical findings, ma'am. And study the examination and distribution of PCOS phenotypes, you have find that that obese PCOS mostly they are coming under severe phenotypic variety A. That is 59.2% of the cases in obese groups were come under phenotype A, ma'am. Whereas in lean PCOS, the prevalence is among phenotype C and phenotype D, which is 62.2% peoples are in lean PCOS coming under milder variety, ma'am. And regarding the metabolic parameters, if we are analyzing, there is an abnormal sugar levels and lipid profiles more among the obese PCOS, and mainly the BMI is influencing the metabolic parameters, ma'am. But the endocrine parameters, when we are analyzing the serum FSH, LH, and AMH, that is a distribution among the both the groups were in the normal limit, and there is no much significant level of difference between both the groups, ma'am.
So what cutoff you have taken for the blood sugar, because you have taken only fasting.
Yes,
So you
ma'am.
told anything, what cutoff you have taken? What is the cutoff fasting blood sugar?
Ma'am, 90 to 100, ma'am.
And because they are non-pregnant, you take the cutoff around 110. Pregnancy, we take the cutoff 90, 92. So you have taken the cutoff as 90 to 100.
Yes, ma'am.
You told those patients whose fasting blood sugar
More
is
than
high.
125 impaired glucose level, and more than 140 is diagnosed as diabetes, ma'am.
More than 140 fasting.
Nice.
You have taken cutoff 140. What is your cutoff for the fasting blood sugar? Because you are taking only fasting sugar, metabolic profile you are taking lipid profile and this, and the sugar you are taking only fasting. So what is the cutoff? What level you do the PPBS or HbA1c?
Fasting and HbA1c, ma'am.
No, at what
5.9.
cutoff of fasting would you go ahead and do HbA1c and PPBS. You told us, no, if it is diabetic levels, if it is high, you will go ahead and do the
Yes.
fasting PP and HbA1c. Which is the cutoff of FBS when you will do that?
More than 110 to 120.
There should be one number, which is the cutoff.
Yeah.
It's not between this. There's one number which is a cutoff.
But you have to take in your study. See, ideally, non-pregnant patient cutoff is 110. When
Yes, ma'am.
100 to 110, they tell it is a maybe little like abnormal
Okay.
glucose. So, what cutoff you have taken?
Ma'am, less than 100 milligram per deciliters is normal, ma'am. 100 to 125 I consider as a pre-diabetic or an impaired glucose level. I will further investigate with PPBS and HbA1c, ma'am.
More than 100, you're investigating.
Yes, ma'am. If it is more than 126, I am considered as diabetic, ma'am.
Okay. Now that you have to mention. That's what you told something 140. What is that 140 fasting? There is no 140 values. So less than 100 you have taken normal, 100 to 125 abnormal, more than 126 diabetic. Okay.
Yes, ma'am.
Ideally, next, if you're going to do any follow-up of the study, then
Yeah.
start with either FBS, PPBS, or Madam already said, even a OGTT is good enough, or a
Yeah.
plain HbA1c.
Yes.
Yeah. Try to incorporate that if you're going to follow up on the study.
Okay, ma'am.
Yeah.
Okay, then next what you did tell me that what is your result like obese and this lean PCOS regarding the metabolic parameters?
Metabolic parameters, mainly the derangement is more common, more prevalent in obese PCOS groups, ma'am. But lean, this metabolic derangement is they didn't exhibit that much of abnormalities in metabolic profile. But their endocrine profile also within normal limit, ma'am. That AMH, prolactin, TSH also, they both the groups there is no difference, ma'am. And there is clinical findings also more among the obese PCOS. When we are actually, I'm not included the fertility management, ma'am. But when we are following our cases of obese and lean PCOS, there is much difficulty in treating the lean PCOS groups.
But the most of your patients are primary infertility or secondary primary both you have taken?
Both, ma'am.
Primary and secondary both you have taken.
Yes, ma'am.
Okay. And the period of infertility?
Uh,
You told you have taken age group 20 to 35.
At 20 to 35, ma'am, but I'm not included the infertility period, ma'am.
Infertility period you have not included. Okay, finally, what is the conclusion?
Then when you are analyzing that obese and lean PCOS, there is metabolic rearrangement is more. Because of the BMI variation, this metabolic derangements is more among the obese PCOS groups, ma'am. When we are analyzing the endocrine, there is no much difference. Then we are concluding that BMI does not influence the endocrine profile. Basically, ma'am, because there is similarity between both the groups. There is no much abnormalities in endocrine profile. So there is these PCOS should have an individual categorization. What is the pathology underlying, and we have to take a further management based on this, ma'am.
So lifestyle management, medication. Did you all give
ma'am.
any of this advice to the patients, obese, following
Yes,
your
ma'am.
study?
Yes, ma'am. I have advised the lifestyle modification and then regular exercise and healthy diet, and further follow up with other any metabolic derangement. I advise for further profile and advice regarding future development of diabetes and hyperlipidemic consequences in the obese PCOS groups.
Okay,
You mentioned like this, you have not taken the infertility treatment part, right?
Yes,
Yeah,
ma'am.
so then, but you told one sentence, no, like lean PCOS are difficult to treat. How did you got that result?
Yeah, usually after basic profile, we used to induce the patient with ovulation induction drugs, ma'am. When we are observing that obese PCOS groups, the ovulatory function is good, but lean PCOS, the development of follicles, there is a difficulty in ovulation, ma'am. When you are following with the follicular study.
So you have taken the treatment part or not?
Not treatment part, ma'am.
Study, treatment part you have not taken.
Yeah, not, ma'am.
You are not included. Only you are seeing the what is the metabolic and the endocrine profile. That's all, right?
Yes, ma'am. Yes, ma'am.
But that's not part of your study, is it?
No, ma'am.
It is not. It will be good to follow up that
Yeah.
as well.
Because that's more important, no? Like
Yeah.
obese and lean PCOS, regarding the fertility outcome, that is because you are not taken any like adolescent PCOS. Most of the patients like you are taking related to fertility. So
Yes,
in
ma'am.
that case, maybe you would have studied the fertility outcome. It would have been much better.
Yes, ma'am.
Okay, maybe you can do like somebody, your junior can do the continuation study of following up with the fertility part.
Okay, ma'am.
Fertility part and this metabolic consider, the FBS alone will not hold water. So you have
Okay.
finished this thesis, huh? Have you? It's been accepted already?
Yes, ma'am.
It's been done.
Yes,
Okay.
ma'am.
So next time, if you're going to do follow-up studies, consider
Yeah.
the OGTT or HbA1c as well. Okay.
Yes, that will be standard this thing for diagnosis of diabetes
Okay.
instead of doing only fasting.
Okay.
Okay.
Nice presentation. Thank you.
Yes. Thank you. Thank you.
Thank you, ma'am.
Thank
Thank you, Priya. Next, anyone is there? Dr. Soundri is there? Did Dr. Soundri joined? Okay. So if at all any other doctors
Any
like
doubt they can ask here.
Shivani,
Shivani, yeah. Pavitra.
so anyone interested to discuss? Any questions regarding the
Pavitra or
thesis?
Shivani, can you present something in short?
I think no more.
They're scared, basically.
This is not exam. At least no, they can have a discussion actually.
Actually, they
Like
can
it's not exam. Nobody is going to give.
Please, girls, discuss பண்ணுங்க. Don't miss the opportunity.
Just
See, nobody is going.
spend
Yeah.
just 4 or 5 minutes and asking a few questions on your thesis in the exam.
Any
Yeah.
doubts?
And you should be
So
able to
some of
answer it.
in the first year, those who are have some kind of topics you have been in mind, no? You can ask the examiners whether it is suitable
So
to.
one thing, and like in general, I just wanted to tell all the students, whenever like when you give a PG dissertation, the main aim of the giving a dissertation is the how to do the study. Many of the time, I feel the students they try to get a like positive result. So result we should not be worried for what result you are getting. Most of the time, result can be a null. Like you can get the null result also, but more important is how to do the research. For that only in the PG period we give the dissertation. It's not, we are not worried for the, suppose you are getting a negative result, you should not feel bad that you have not done the study. So you should do the study properly. You should not be worried for the result what you are getting. That is more important. So methodology
you're just
should be
stating
very
what you
proper.
found.
Yeah.
Exactly. So you're,
Yeah. Like sometimes what like I have seen some people they just try to modify it so that they'll get a positive result. So that is
yeah.
yeah. So that is not the aim of doing the research. So research is you do it perfectly. Whatever result comes, that's good. We are getting a real result, not necessarily to show it all the time. It is like it is coming. The hypothesis always may not be true.
Yeah, the statisticians always guide us on that point. And we shouldn't be worried about what the result outcome is, you know.
Yeah, yeah.
It's very
So more
important.
important
Don't
is
try
like
to manipulate to get a positive outcome.
yes.
So your research will also guide further, further treatment options or something. So we can use your research findings to
Correct.
modify our treatment in our institute. See if it's going to show a negative outcome, fine. This is something we will not be picking up or using. So that can also help out, isn't it?
Sometimes they have a misconception like results should be always positive. Because when you're doing a real research, result may not come positive, and that is only we need. Because everybody will show like some manipulation showing a positive result. That's not going to help. That is not going to help means it is the purpose of doing a research is not solved.
And those who haven't yet chosen their thesis topics, choose something which is unique but not too difficult, and you're able to have only a few parameters which you have to consider. Okay, don't go and have the whole gamut of data. Small number of data, but a unique topic and which you can finish on time, but which will also be meaningful in the end.
Yes,
it's very
that is more
important that you
important.
have a good. You are interested in the research. You love doing that research. The topic is something you actually like, just not random because you have to finish a thesis. It's something where your interest lies. That will make more difference how you go about collecting the data and everything. If you're interested, you usually do a good job of it.
Is it always to do a prospective study in thesis or
Yeah.
retrospective will be expected?
They
No,
accept
prospective will be always
prospective
better.
is always better.
Always better. Because retrospective means they are just doing the data collection. They
Yeah.
are not doing
Most
any
of
work.
the
So,
postgraduates do prospective only because they
Yes.
start with the study period, and most of them
yes,
do
yes.
prospective.
Yeah, most of them do prospective only. That is
But
true.
when you have a smaller number of your number is small, then they sometimes consider a few retrospective and prospective. So it goes on, you can take a few retrospective also. So combined retrospective and
Combined.
prospective is also allowed.
Yeah, allowed, but
And
they have
instead
to
of
take that ethics committee approval as well for that.
Yeah,
Mm.
yeah. They have done. Some of our students have managed to get the approval for that.
And instead of doing only observational study, better to go for some RCT. That is more meaningful, and it will be also like for publication also it will be good. And the topic also like study will be good power study if you're doing a RCT. Instead of doing more only, and nowadays so many PGs like in each and every medical college, finding and giving a topic is also it's very difficult. And
Yeah.
feasibility of doing the study, that is also more important.
Okay. So all the prospective study also they need an ethical committee approval, right?
Yeah, definitely.
Yeah.
All of
Any
the thesis
study,
go through.
Every study
efforts
needs
have
an
to go
ethical.
ethical committee.
All thesis also they needed it.
All thesis.
Yeah, all thesis. In the first like in the first year itself, they have to set the proposal and like present in the ethical committee. Once is approved only, they can go ahead with the study.
Even government colleges, Veena?
Yes.
Okay.
Research is everywhere same. No government, private, it don't change.
No, I
As
can't
a
remember.
review
But-
board, no? I think they
yeah.
also have an internal review board for that, right?
Yeah.
We
Okay.
have in Ramchandra, we have all of our students get it. Then only they are supposed to start the study after
Yeah,
the
without
Right.
ethical committee
Even we
approval, they
have,
cannot
madam.
start. And when
We
they
have a
submit the
scientific and
thesis,
ethical clearance.
yes. And
Both,
when they
madam.
when they submit the thesis, they have to give the ethical committee certificate also. Without that, they cannot submit the thesis.
Yeah.
Okay. Yes. Okay.
We
Thank
also have a review before the final
Yeah.
thesis is sent off to the board. So that, our committee should also approve of the thesis before it's sent to the board, the final copy.
Yes, final copy.
Suppose if the final copy is not approved,
No, they give us some query. Oh, no, they will
Okay.
tell us to modify certain things.
Modify.
You
Usually
can
nobody
send
can.
it, yeah.
No, usually
don't
nobody
reject at the
cancels
end,
the
madam.
study. Because whatever it may be, students have taken so much of pain and this thing to do the study. Usually
They
nobody,
may be
because I do a lot of thesis like corrections I usually do. So we usually I just write and give what are the pro and like changes to be done.
Yeah. See, if we don't go through that process, then the board sends us queries which we must
Yeah.
answer, modify the
Yes.
thesis a bit based on their queries. So we finish it off here. Most of the time it's accepted directly by the board. We do the changes before sending it off.
But in MD, these things I have seen usually nobody reject the thesis. But DNB, I have seen one surgery candidate 5 times his thesis was rejected.
why?
Hi.
Maybe like it would be very bad, no? Otherwise, why somebody will reject 5 times?
Usually
Was it
the
too
guide
soon?
checks, madam. The guide and the co-guide. The
Yeah.
co-guide will check and the guide will verify. Then only like it will be submitted.
Yeah.
That we do, but somebody like one candidate I know that he is now a consultant, whatever it may be. But 5 times his thesis was cancelled because he was not
Quite stressful
taking any
during the
advice.
postgraduate times.
Mm, okay.
Okay. Looks like nobody else has anything to ask
I
or
don't
present.
think,
It
yeah.
looks
You
a
can
lot of
call
first
by
year
individual
candidates here
names.
probably.
Kavinila. Any doubts? Kavinila, Amudan. Priya, are you ready with your quiz?
Girish.
Subhash,
Quiz.
Shivani.
Yeah.
I think Priya is busy with her some delivery is happening.
Okay.
If no more
Yes, ma'am.
questions, we'll
Yeah.
wind up, madam.
Madam, sorry, deliver பண்ணிட்டேன். So வந்துட்டு
Okay.
I'll ask somebody to share the Kahoot. And
Okay.
can Deepa madam, can you just go on with the quiz? I will ask somebody to share it from my laptop, madam.
All
Okay,
those who
That
have
is
logged
okay.
in, please continue.
I have already logged in, madam.
No,
I
the
have already.
students, please don't log out. Participate in the quiz.
Yeah.
Are they there now? I will share, madam. Are they there yet, madam? இருக்காங்க தானே?
ஒரு 20 பேர் இருக்காங்கப்பா பிரியா.
அப்ப ஷேர் பண்றேன் மேடம் நானு.
Including
ஒரு
the
2 minutes
faculties,
எனக்கு கொடுங்க
24
மேடம்.
members are there.
I will just share. Give me just 2
We'll
minutes,
also
madam.
participate, Priya.
Yeah,
We'll also
sure.
participate.
Definitely sure. ஒரு 2 minutes மட்டும் 2 minutes. அந்த இது
Thank you,
மட்டும்
Dr. Bhuvana ma'am, Dr.
mute பண்ணிடுறேன்.
Sunita
இது
ma'am,
cancel
and
பண்ணு.
Uma ma'am.
Thank you.
Thank
Thank you, Sunita ma'am,
Thank
Uma
you
ma'am,
all.
Thank you,
Bona ma'am.
Deepa. Thank you, Meena.
Thank you, madam.
Thank you, Uma
Meena
ma'am.
isn't participating in the quiz this time, are you?
Yeah, you can
Last
allowed,
time she
madam,
was
but
doing very well.
you are allowed, but if you are in the first place, we won't be giving the first place. It will
You won't give the
automatically
Yeah,
go
yeah.
to the students. Students alone will be
Yeah.
getting it.
Yes. It's just for fun to be there in the quiz. I
Okay.
really like.
Yeah, Priya, you can share the Kahoot screen.
I think she's setting it, madam.
Actually, you could have asked Chitrakala to do it, Priya. So in the meantime, there is no question in the chat box, right? I think some presenter has to come, Soundri. She has given the name. After seeing the first presentations, I think she left it. How to select a unique topic, madam? There's
Unique
so
topic,
so
huh?
much of things now. How to select it? Like,
First, we have to decide where our interests lie in, and then work towards it.
And in
What's
our
your interest?
hospital, if after finding so much, if you have chosen the topic, then you will find someone else would have taken the topic. So you have to find out from others also what they have taken, then exclude that and find out. Because 18 students are there, so it's difficult. So last time I don't have usually difficulty, but this time whichever topic I chose, someone would have taken that already.
Mochi, the commonest they are targeting is GDM, DM, hypertension, because the numbers are much high, right? So most of the students work just around these topics.
And normally, like within 5 years, topic also should not be repeated in a particular
Repeated.
college.
Yeah.
University. That is also there.
That particular
Slightly change the
university.
topic heading so that it doesn't
Yeah.
appear the same.
I think she is creating the pin.
மேடம் இன்னொரு கம்ப்யூட்டர்ல இருந்து நான் லாகின் பண்ணிருக்கேன். Can you see my Kahoot and can you see my screen?
Yeah, I can able to see the screen.
Okay. Please mute பண்ணிடுறேன். அது
You are sharing the Kahoot pin, right? Creating. So everyone go to www.kahoot.it or open your Kahoot app and enter the game pin. So 2 have joined, 3. Anyone is having a difficulty, please mention in the chat box.
What is the quiz on?
It's a miscellaneous mixed bag, either in CTG or in.
Yes, madam, it is a mixed bag. So we have given you multiple, images, recent advances, some few trials, some blood test, LMA. So Deepa, madam, please take over. My PG will be changing the slides. You please read out, madam.
Okay, ma'am.
Okay, thank you.
So only 10 candidates have joined.
Okay, and so I will start here, madam.
1 second, wait for 2 more minutes, 5 more
Okay.
minutes.
Okay, the mute connect.
11 candidates have joined. So just mention in the chat box, we have to wait or we can start. Once we started, you cannot able to join. Please join soon. Any more to join? Totally 12 have joined. Any difficulty in joining, please let us know, please. So there is the idea of joining, one is you know what to do. Second, if you do it in your Kahoot app, these all the questions will be saved in your Kahoot app. So for your future reference, it will be very useful. So I wish all of the people, all the PGs especially, please join. You can get to know the questions and answers. Two more minutes, we will start. Fifteen candidates have joined. We want another 5. Priya, I think we can start, Priya. So we are starting. 3, 2, 1. Go. The first question, which receptor is predictive of response to progestin therapy in advanced or recurrent endometrial carcinoma? Is it P53, ER, is it HER2 or P10? So the correct answer is ER. Only 5 candidates have answered correctly. Next question. Skip the scoreboard. The second question, fertility sparing a treatment not done in endometrial carcinoma if pole mutation presence of lymphovascular invasions, no myometrial invasions, endometrial adenocarcinoma. So the answer is presence of LVSI. Third question, which is not an advanced energy source in laparoscopy? Harmonic, thunderbeat, ligashwar, bipolar. Simple. I know. So the answer is bipolar. So fourth question, false regarding advanced bipolar energy system is seals vessels diameter of 7 mm, faster time, it can cut using the same energy source, less smoke. Do not write in chat box. It can cut using same energy source. The correct answer is next. Wrong statement regarding harmonic scalpel. Used sound energy, both the blades of the device vibrates, can coagulate and cut, dissection done with cavitation. Five minutes, 5 seconds to go. 3 seconds. 1. And the answer is both the blades of the device vibrates. It's not dissection done with cavitations. Question 6. Laser in laparoscopy is best used for endometriosis, lymph node dissections, bladder dissection, adhesive lysis. Five seconds. 2 seconds. Yeah, the answer is endometriosis. And SJB leads. What is CHAP trial in pregnancy? Is it control of hypertension in pregnancy trial, chronic hypertension in pregnancy trial, children auditory performance scale, or comprehensive hospital EGIL preparedness? It is chronic hypertension and pregnancy trial. So good, 9 answer correctly. Next. Question 8. Emerge trial is on which disease? Hypertension, GDM, obstetric emergency, emerging infectious disease. Five seconds to go. Yes. The answer is GDM. 8 wrong answers. SJP still leads the board. Aishwarya is climbed up. ASAPP trial is for placenta previa, prevention of PPH, PUPS, and preeclampsia. Since it is a clinical research skill hours, we have lots of trials in the questions. 5 seconds more. So it's for preeclampsia. Next. So AKR leads, followed by Pavitra. IVIDA trial is for anemia, diabetes, antibiotics, AI in pregnancy. Artificial intelligence. That's not an answer. I'm just telling AI. What is AI? 5 seconds more. The answer is anemia. IV iron deficiency anemia. So Pavitra leads. Identify the ovarian tumor. It's a serous adenocarcinoma, dysgerminoma, Krukenberg's, or dermoid. I think it's an easy pick. Great. Krukenberg, 7 answer correctly. It's a bilateral. That's a clue here there. And 12th questions, identify the lesion. It's a CAN, papillary cervical cancer, cervical ectopy, or cervical ulcer? Five seconds more. So the answer is CAN. AKR leads this board. Identify the procedure. Lighted stent in ureter, sentinel lymph node biopsy, ICG for tumor identification, and peritoneal metastasis identification. What's that? Sentinel node lymph node biopsy. Great. So, identify the skin lesion in pregnancy. Is it PUPS? Is it pemphigoid? It is psoriasis or atrophy? It's Priya madam's favorite. So, that's why the people have answered PUPS, but it's pemphigoid. Identify these painful skin lesions will appear on the woman's back. Is it PUPS? It's pemphigoid, it's herpes zoster or folliculitis. Yes, it's a herpes. Pavitra leads the scoreboard. 16th question. The most probable diagnosis is a hemoglobin electrophoresis, which is a normal pattern, or thalassemia trait, or thalassemia major, or sickle cell. Yeah, the answer is the thalassemia trait. Next. So, next was 17th, the most probable diagnosis. So, this is a sonography picture with Doppler, ovarian dermoid, corpus luteal cyst, mucinous cystadenoma, or ovarian malignancy. 5 seconds more. So, it's ovarian malignancy. It's not dermoid. Question 18. The Doppler study of which vessel is given in the above image? Umbilical artery, is it a uterine artery, or is it ductus venosus, or aortic arch Doppler? See, it's uterine artery. So, Pavitra still leads the scoreboard. Next one. 19th question. High MCA PSV signifies maternal anemia, FGR, fetal anemia, impending stillborn. So, the answer is fetal anemia. Next. Give the most probable diagnosis. What is it? Is it polyp, endometrial polyp, or intramural fibroid, or thin endometrium, or endometrial cancer? It's endometrial cancer. A leash of corkscrew type of Doppler. Give the most probable hysteroscopic finding. What is this? Myomatous polyp, pedunculated polyp, septate uterus, or is it endometrial hyperplasia or cancer? The question actually is leaked out. The answer is there in the picture itself. Endometrial hyperplasia or cancer. So, Pavitra. Question 22. Radical trachelectomy is done along with the following except. cervical encerclage, lymph node dissection, sentinel lymph node sampling, and bilateral salpingectomy. Answer is bilateral salpingectomy. So it's a little tricky question. Next. So the scoreboard, 23rd question, give the diagnosis. Again, the scan picture, is it septate uterus, isthmocele, nabothiensis, or myometrial cyst? And this is an easy pick. Correct, great. So it is isthmocele. Next question. Question 24, identify the investigation and diagnosis. What investigations and the diagnosis? Is it TVS and Copperty, or it is TAS misplaced Copperty, or 3D TVS displaced Marina, or 3D TVS Marina? Correct. It's a 3D picture. The last one, next question. Give the diagnosis. Is it a 3D TVS endometrial polyp, or 3D TVS saline endometrial polyp, or saline sonogram and endometrial polyp, or 3D TVS submucous polyp, or submucous myoma? It's a 3D TVS saline sonogram which shows endometrial polyp. Now, who is the winner? Second runner-up is Aishwarya. Congratulations. And first runner-up is Pavitra. Congratulations. And the winner is AKR. Congratulations. And just mention your name, full name, proper name in the chat box and your college. So all have got 17 out of 25 correct. Only the speed which they answered, they laid the scoreboard. So almost all are in the same boat. Congratulations. Please mention your names. Thank you, everyone. And the winners, please mention your full name in the chat box.
Madam,
Thanks, madam.
unmute பண்ணிட்டியாடா? Madam, sorry, madam, I could not log in. இப்பதான் முடிச்சேன். I'm there doing my episode.
I just, thank you, PK. I just wanted the winner name AKR. Who is AKR? Ramya AKKGH. Congratulations. Pavitra Swarna SMF. Congrats. And one more person, the last. Thanks, Bhumana. Thanks for staying back.
Thank you. Nice questions.
Yeah.
Nice
Priya,
questions.
you're
Excellent.
the queen of trials here.
Excellent
Okay.
questions.
Bye.
And
Thank you.
pictures also.
Bye-bye.
Bye-bye.
Thank you so much for logging
Congratulations.
out. Thank you all. Bye.
Thank you, Mama.
Thank you.
Aishwarya Suresh is from SMF. So the two toppers are two runners from SMF and the winner is from KGH. Congratulations. Priya mentioned.
Congratulations, quiz masters and Priya Kannappan, Dr. Deepa ma'am, and also the winners.
Thank
Happy
you.
to see the quiz. Yeah. Thank you.
Thank you, Meena. Thank you, Deepa, madam. Thank you.
So thank Chitrakala for sharing us the platforms and staying with us. So we'll leave the podium. Thank you, delegates. Thank you, students. So we'll see you next last Tuesday of next month. Okay.